Hi, everyone. Welcome to the ACUFP, the patient perspective of continuous glucose monitoring.
So, hi, I'm Dr. Kim Fotenhauer. I am an assistant professor of family medicine and fellowship trained diabetologist. I'm also the assistant dean of clerkship education at Michigan State University College of Osteopathic Medicine in East Lansing.
And my name is Dr. Goyal. I'm a family practice physician and also working as a hospitalist at Prestige Hospital, Corpus Christi, Texas.
Our learning objectives. So we're going to talk about selecting the appropriate CGM device based on the patient history or any other characteristics. We're going to address patient questions related to the use of CGM and glucose monitoring, and then identify support strategies for patients using CGM to monitor their blood glucose levels. So let's just talk about some basics, kind of the CGM, the what and the why, and how this works.
So, one of the things that we find with continuous glucose monitoring is it gives us a more full picture of what's going on with the patient. So if we look at the simple animation where green is where we want our blood glucose readings to lie, yellow is hyperglycemia, and red is hypoglycemia, if we just have individual readings, it looks like everything is great, everything is within the green. But next, if we fill in the continuous glucose monitoring, we then see connecting the dots that there is episodes of hyperglycemia as well as episodes of hypoglycemia.
So this is the nuts and bolts of how it works. So we have on the skin, you insert a sensor. The sensor is flexible, a little flexible piece of kind of plasticky stuff. Use a needle to insert it, but very small. It's all contained nowadays in one kind of unit. Put that on the skin, pop that in, the needle comes out, the catheter stays into the skin and gets into the interstitial fluid. There's then a transmitter on the outside of that sensor. So sometimes they're combined, the sensor and the transmitter together. Sometimes that sensor stays in and the transmitter can come on and off attached to that. The transmitter then goes to a reader, and the reader can either be on your phone. Nowadays, almost all of them are on your phone, but don't let that stop you if you have older patients that don't use smartphones, because there are still some with readers that you can prescribe as well. And then you have the reader right there to talk to the CGM, and that's where you get your information. So the information can either be directly onto your phone or onto a reader. And with that, with those readings that come in, we can look at a discrete glucose. Some of them do it real times, every minute, monitoring every minute. Some of them send it every 15 minutes. But then also we can look at trends. So sometimes the trends are going up and going down, and set alarms for these, because that's really what we're interested in, right? Not just that discrete glucose, but which direction is it going? And that can be more information for your patient, and then it collectively can be more information for you to change what you need to for your patient.
So what is the mechanism of action for a CGM device? Basically, a flexible filament is embedded into the skin, and the enzymes on the tip of the filament interact with the glucose molecules present in the fluid between the cells, what's called the interstitial fluids. It causes an electric current to be produced, which is translated into a glucose concentration number. This measures the glucose content in the interstitial fluid, which correlates with the plasma glucose levels. So, accuracy of the CGM device. Now, when the blood sugar levels are rapidly rising in the human body, the blood sugar levels tend to rise faster in the blood plasma when compared to the interstitial fluid. The CGM device is only checking the blood sugar level in the interstitial fluids. Therefore, there will be slower rise in sugar levels detected by the CGM monitor. So even though despite there's a brief delay, the CGM is still highly accurate and can send alerts when the rate of change is rapid. And the CGM will give you a trend on how rapidly the sugar is rising. Even though the delay would be about 5 or 10 minutes, it's still accurate enough, and it still will give you an accurate reading. However, it is still always important to have a finger stick glucose as a backup for CGM.
Okay, so what kinds are out there? So there's several different kinds, several different brands. There is, first of all, thinking about personal versus professional. So personal is a device that the patient gets and as you prescribe for them. They have it, they take it home, it is theirs, they get new prescriptions on sensors or transmitters if they need that you write, and we'll talk a little bit more about writing prescriptions. But they keep that device is theirs. And then there's the professional, and several of these have professional options where the practice owns the CGM device and gives out to the patient the sensor and the transmitter. Sometimes that's blinded, sometimes that's unblinded. and the patient wears that for anywhere from 10 to 14 days. And that is more like a snapshot, right? And so you get a snapshot of what they're doing for those 14 days. There's differences in how the CGM reads. And so there's real-time CGM, which is just like it sounds, right? You're getting readings about every minute, and that's getting sent to your transmitter or to your reader. Then there's intermittently scanned, and so that happens kind of intermittently, so it's every 15 minutes, or it's when you take the reader and you scan the device, and then you get the reading onto your reader. So a couple of these that you're going to see up here. So there is the Medtronic Guardian that is up in your left-hand, top left corner. There is Freestyle and Libre, and they have several different kinds. So they have a Freestyle 2 and a Freestyle 3 that just came out, and then a 14-day. Dexcom, you'll hear Dexcom has a G6 as well as just a G7 that was just released. And then an Eversense. And an Eversense is a little bit different in that it doesn't have a device or a sensor that gets replaced every 10 or 14 days. It actually has a sensor that gets inserted under the skin, sort of like a Nexplanon type of a deal. And it gets inserted there and stays there for 180 days. And so under the skin, then you have a transmitter that goes over it, and that sends the readings to your reader.
So, Dr. Goyle, we have a number of differences between the different devices. One of the important differences is the length of wear. Can you explain to us the length of wear for the different devices?
So yes, the Freestyle Libre 2 lasts and the Libre 3 last a total of about 14 days, whereas for Dexcom G6 and 7 can go up to 10 days. And similarly for Medtronic's, it'll be about 7 days. The Eversense E3 can last up to 6 months, but this is a surgical, this is implanted subcutaneously under the skin, and it can last up to 6 months, like I said.
Great. And I'm sure, that's a lot of patient preference there. So some may want that procedure if it can last up to 6 months. For others, it may be important if they have to switch their device every 7 days versus every 14 days. So something else that I think shows patient preference is the calibration that's required. So can you tell us a little bit about the calibration between some of the newer devices with the Freestyle and the Dexcom versus some of the older ones?
So the newer ones like Freestyle Libre 2 and 3, and similarly Dexcom G6 and 7 require no calibration. The older Medtronic Guardian 3 requires calibration every 12 hours, or 3 to 4 times a day is recommended. And similarly with Eversense E3, it's required every 12 hours for the first 3 weeks and then once daily. The Medtronic's Guardian G4 does not require daily calibrations.
Right. And I know some patients that's really important, right? Do I need to stick my finger to calibrate, even though I'm already wearing this device, versus is it a factory calibration? So the other thing I think that it's important both on the physician side of things and on the patient side of things is knowing what to order and what needs to be worn. So some of these devices include both a sensor and a transmitter together, and others you have to order and wear a sensor separately from a transmitter that goes over the top. Can you walk us through the differences on these devices?
The Libre 3 and Dexcom have a sensor and a receiver together, whereas the other devices that you're talking about, they all come separately and needs to be attached, I guess, when using.
Right. So some of those transmitters can be reused as long as you change out the sensor versus others that are combined together. So the Dexcom G7 and the Freestyle Libre 2 that have those together, it's a little bit easier to insert. It's a one pop, right? To get them both on there together versus others where you're going to change out the sensor and the transmitter.
Correct. Yes.
All right, so let's move on to a little bit of the science behind this, right? So the evidence for using the real-time CGM. So a lot of these studies have started off in type 1, and now we've moved over a lot to using CGM in type 2 as well. And so these top couple of studies, the biggest takeaway, I think, is this big chart is that there's been multiple studies in a bunch of different populations, and they are looking at a couple different things. But for the majority of them, they're seeing lower A1Cs, less and less hypoglycemia. And I think less hypoglycemia is really key. They started off in type 1 population, but they also have adult type 2, and then they have an elderly population too, those over 60. One of the most recent ones was the MOBILE study. So the MOBILE study looked at type 2 diabetes on basal insulin without prandial insulin, and those were in primary care practices, so they were being managed by us. They were looking at whether continuous glucose monitoring improved A1C levels. So it was a smaller study, 88 men or 88 women, 87 men, but they compared it to using a blood stick glucose. Found that there was a decrease in A1C of about almost 1% for those on continuous glucose monitors, a decrease as well of those using the blood glucose monitors. So again, anytime we're monitoring, we're showing an improvement there. But the risk adjustment was significant of about negative 0.4% for A1C. Doesn't sound like a lot, right? But that can make a big change in a patient and prevent some complications in the future, microvascular complications. This was another study that was done that was retrospective. And so it looked at observational study, looking at chart review, taking out patients with type 2 diabetes, less than 65 that were on basal insulin or were on non-insulin. So this is one that looked at those that weren't taking any kind of insulin. They had to have an A1C of greater than 8%. So looked at that if they were prescribed a CGM. So again, because it's observational, we don't know if they ever actually filled it, right? So that's one of the drawbacks of this study. But it was someone that was given an opportunity to have a CGM. For those patients, altogether the adults had a decrease in A1C of 1.5%. Those on non-insulin had a decrease of 1.6%, and those on basal insulin had a decrease of 1.1%. The important thing on the bottom to note is that at the higher percentages, the higher A1Cs of the greater than 12% had a greater reduction in A1C. And so those patients that are more at the higher A1Cs would have likely have a greater benefit from using a CGM device. So how do we read this? This looks a lot different than an A1C number, right? And so this is kind of the part of the drawback. If you're not familiar with this, is getting familiar with something that's new. When a patient comes in, you can either download from their device directly, or now most of them are also have an app that you can download directly from them using a code. When we're looking at this, on this top, the top right-hand corner for you guys is going to show your date range and the percentage of the time that the CGM was worn. So in this one, it says 100%. I know that's really little on the screen. That's just kind of giving you a basis of how much data you're getting. It's going to give you underneath that your average glucose. That's going to translate into a glucose management indicator. This is going to look a little bit more like an A1C. However, it's really just for those 14 days. It's not averaged over those 3 months. So it's really just that little bit of a snapshot, 10 to 14 days. Underneath that, you're going to have a glucose variability. So that's kind of comparing day to day, how much there's a variation in that same time frame from day to day. What we're really interested in a lot of times is this time in range. And so know that you want to look at time in range. Time in range tells us where that target glucose is, how much out of their day did they spend in that target range. We also then have time above range and time below range, which is the red up here that you see, the time below range, and the yellow, which is the time above range. You see that in the little vertical line off to the right, and then you also see that in the center part, those up and downs, those are overlaps of all of the days. And so combining those 10 or 14 days into one chart. And then way at the bottom there, you'll see those glucose daily profiles. And so those break down every day where they were up and down. And that is the information that was used to create that average one that's in the center. So for most people with type 1 or type 2 diabetes, if their goal is about 7%, we want their time in range to be about 70%. It kind of correlates, and so it's nice and easy to remember, right? Their time below range, we want to be less than 4%. And I think this is one of the places that CGM kind of shines, is that we can really identify those hypoglycemic events, and sometimes those that are happening when we're not aware of them. Mm-hmm. And then time above range, we want to be less than 25%. I always say that I would rather have my patients too high than too low. It's more dangerous, right, to be hypoglycemic than it is to be hyperglycemic. And then looking at that glucose variability, so what it varies day to day, and we want that number to be less than 36%. This is a little bit closer look at that vertical line that tells us the percentage of time that they spent in all of these areas. So again, TIR, or time in range, we want to be about 7%, and that correlates to an A1C of 7%. Remember though, for our patients that have a higher A1C goal or higher glycemic target, we would want to adjust that time in range or where we want their goal. The adjustment is that every 10% increase in time in range improves A1C by 0.5%. So if I have a 10% increase in time in range from 70 to 80, I could project that that A1C will drop from 7.5 to 6.5. This is a little bit more difficult concept for patients to understand because they always want lower numbers, right? We've told them forever, we want your glucose lower, we want your A1C lower. And now we're talking about it going a bit higher. We're talking about that time in range going up rather than going down. So this is a really important concept. And I love that they have the colors, right? The colors kind of, we're innate that that's what we want. The goal of time below range, which is that red or that hypoglycemia, below 70 or below 54, we want less than 4%. And about 1% is about 15 minutes. And so the lower that we can get on that is improvement for our patients. So some recommendations from our societies, professional societies. So the American Diabetes Association recommends that professional CGM or intermittent real-time CGM can be helpful in improving and correcting the patterns of hyper and hypoglycemia to improve A1C levels in people with diabetes on non-insulin as well as basal insulin regimens. The American Association of Clinical Endocrinologists and the Endocrine Society recommend CGM devices to be considered in all patients with type 1 and type 2 who are in intensive insulin therapy to improve A1C levels and for reducing problematic hypoglycemia. So to me, those are the couple of times that I really want to think about using CGM is when someone's on insulin, and that's getting less for our type 2s, definitely, right? Fewer and farther between. For our type 1s, definitely think about CGM or a combination. And then anytime there's hypoglycemia or suspected hypoglycemia, if I had a patient with suspected hypoglycemia, this might be a great time to use a professional, right? Not have to have a personal one that's prescribed for a long period of time, but get that snapshot of what's going on. So these are indications for who to think about. You'll notice with these recommendations, they say adults with diabetes. They don't say necessarily type 1 or type 2. But anyone who's on multiple daily injections or an insulin pump should be considered. Adults who are on basal insulin, youth with type 1 that have multiple daily injections on insulin pump, and now youth with type 2 as well on multiple daily injections with insulin pump. There's other cases where they may be sometimes helpful. And so women with gestational diabetes, there are a couple devices that are approved for use in pregnancy and can be useful for those patients with gestational diabetes. Sometimes if there's a mismatch between a finger stick glucose and an A1C, so you have that patient that comes in and brings their logs, and their finger sticks look great, but their A1C is like 8-9%, right? And you're confused as to why are we seeing this, and then their A1C is elevated. That's another great time to do just a professional or think about a personal, but a professional one at least, to see what is actually happening, what are those glucose levels. Remember that finger stick is just a snapshot, and we want to get that full picture of variability. And then those that have any concerns for hypoglycemia, and so we talked about that a little bit. If they're going low or you suspect they're going low, this is a great time or a great way to see if they truly are. Patient education and how to order, and so we're going to talk a lot about how to order in just a second, but we want to manage patients' expectations about this. Who has ever gotten a denial for one of these? Yeah, absolutely. It happens all the time, but there are resources that can help us walk through that. So one is picking the right patient for these. Two is knowing the right process to go through, and we'll talk about that. But then resources, so we want to have that conversation with the patient, right? Managing expectations about how this is going to work. And this may not be something that you can go and get that day at your pharmacy. I expect it not to be, but it's something that we're going to begin the process of. Patient handouts, patient education videos are great. For our younger generation, just saying, go on YouTube and Google, YouTube this, you'll find something on it. And there's great videos and advice out there. An educator in the office, if you have it, or an educator that you know of that you can send them to. And then once they get it, having that really close follow-up in that first week or two of wear to start to troubleshoot what they weren't expecting. And then also our representatives from the device companies. And so sometimes if you don't know kind of which direction to go, you can call them up and say, hey, I have this patient that's perfect for this device. How do I get them there? How can I help that? And you'll eventually be managing that and writing the prescription, but they can help you navigate through that system to get the patient what they need. Okay, so insurance authorization process. So many prescriptions require that you most of the time you're prescribing this like you would a medication. So your EHRs may already have this integrated into them. With Medicare, it covers CGM under durable medical equipment. So the benefit is not through the pharmacy, but through their DME supplier. You often need a certificate of medical necessity. So that's something that you can put up and save, and that's something that can just be sent off anytime you're ordering one of these. And then chart notes. So often there needs to be chart notes that are documented that are sent off with the prescription as well.
So there's the approved sites for the CGM devices for Dexcom G7, Guardian Sensor 4, Freestyle Libre, and Never sensors at the back of the arms. And Dexcom G7 and Sensor 4, Guardian Sensor 4 can also be used on the back of the buttocks and thighs. The real world we are seeing that patients are also using are on their abdomen and also on the front part of their thighs and also on the front of their arms. So physicians should ask their patients where exactly they are wearing their CGM devices. We should be also asking them to change their CGM device locations and also check the location where the patients were wearing CGM devices just to make sure it's not getting infected or signs of cellulitis or anything like that.
What you're prescribing. So this is a little bit dependent on which one you're prescribing and whether the sensor and the transmitter are together or are separate. One of the places that we have as a resource at the end is DiabetesWiseorg, and that'll be in here. It is a non-branded organization that looks at what different technology is out there and really walks you through what you need to order for each one and what the steps are. So it's a great resource to start, or even send your patients to the DiabetesWiseorg, which is the patient-friendly site, to look through the different devices and decide which one is right for them. Then the sensor and the transmitter often are written as a prescription, knowing how many boxes to fill, so 10 versus 14 days, how many are given at a time. And then the receiver, so there's still a couple out there with receivers and you can write a prescription for the receiver, but many of them now have an app that goes on your phone, which is convenient if you have a smartphone. Some of your patients won't have a smartphone, and so there are still the readers that are available that you can prescribe or don't want it on their smartphone, but often you can just do it right there. Examples of chart notes are in here, and so this is something that you can just put into your chart note, have it saved as a template or whatever it is, so that it's right there. It's sometimes helpful to quote the American Diabetes Association Standards of Care, because then you're showing that you're following someone's guidelines to do this for your insurance. Billing, you can absolutely bill for this. So you can bill for a glucose start, which is that top CPT code for if you're starting a personal CGM. You can bill for if you're starting a professional CGM, that's that second CPT code there. That is billed once every 90 days for most insurances. And then you can also bill for the monitoring of it and the interpretation. And so that is billable one time per month for most insurances. Okay, so using CGM with your patients. So let's walk through a case study real fast. So Anthony, he's a 60-year-old male, presents to your office for a follow-up of a diabetes visit. He has a 10-year history of type 2 diabetes. His point of care A1C that day is 8.8%. So he complains of 2 episodes of symptomatic hypoglycemia. He has the shakes, nauseous, weakness in the past month. He's checked his blood glucose during these times and it was about 65. He states he also had 1 episode of syncope, but he did not check his blood glucose at the time. He usually only checks his blood glucose when he feels shaky, and today he did not bring in his glucose logs. So he's 5'9" tall, weight is 205, a BMI of 30.3. He's currently taking metformin, 1,000 milligrams BID, glipizide, 10 milligrams, and insulin glargine, 40 units in the evening. Okay, so problem list. So where do we start for this? So A1C is above target. He's had these questionable hypoglycemic episodes, 2 documented, 1 may be questionable. He's got low data, so we don't know, he's not checking his glucose regularly. So we don't have the information, he doesn't have the information. He's a candidate for CGM because he has basal insulin, he has hypoglycemic episodes, and he's not a goal for A1C. So this is the kind of patient that I would see and think, this is a great place to start. This is a great thing to give him to help him with all of these issues that we have on his problem list. So we do that, we give him a professional one, he wears it for 14 days, and he comes back with this sort of a reading. So what do you see here? Some of them are circled in red for you to know what you're seeing here, but what kind of things would you start to approach with this patient? Stop the sulfonylurea, right? So hypoglycemia. So the first thing we want to address with him is probably his hypoglycemia. So stopping the sulfonylurea if we can, absolutely, because we're seeing these lows and we're seeing these lows overnight. So this is not, he's at 5% of hypoglycemia in his AGP. And so it's not a super significant part. It's above where we want it, but he's having the hypoglycemia at night. And we know we have 2 documented cases. What other things do you want to think about with this patient? Premeal insulin, sure. So something is going on with his postprandial excursions, right? He's becoming too hyperglycemic after his meals. Do we want to do prandial insulin, or maybe we could add another medication that would work prandially, right? And so around those meal times, something like a GLP-1 receptor agonist or an SGLT2 inhibitor, something that's going to work with those mealtime insulins. Well, the SGLT2 slightly different, but only in the presence of glucose, right? So would not cause further hypoglycemia. What else do you want to do? What else do you see? So he's spending a lot of time high. He's spending a lot of time within hyperglycemia. And so his time in range is only 53%. So we want to increase that time in range, which is going to lower his A1C. So part of that is going to be us addressing his medications, but I think the other piece of that is going to be education. And so talking about, his food and his food intake, maybe doing a food journal or sending to a CDE or registered dietitian that can talk through those kind of up and downs and some of the choices that he's making on a day-to-day basis. Great, I love it. So we're going to correct the hypoglycemia first. So stopping the glipizide, starting an SGLT2 inhibitor, decreasing the glargine as well. So he's having those overnight lows, and so we want to just scale back on that glargine. We may even want to go further than that. Postprandial hyperglycemia, talking about food habits, sending to someone who can dive deeper into that a bit. And then really our patient, he saw this and he loved having this data without having to stick his finger. So he came back and he was like, I didn't have to stick. And then, because that's probably was keeping him from doing it before. And I got to see what was happening. And I can tell you, this is kind of fun. So when I wore mine, I would just like try out, like, okay, I'm gonna eat a donut. And be like, oh, look at it go. Oh, it's tick, 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 right? Going up. Patients love this. And this is their immediate feedback. Instead of those 3-month feedbacks of where my A1C is, it's their immediate feedback of, oh, if I make this choice, this is what happens to my glucose. If I make this other choice, I can see that it doesn't go as high. And so patients love this, physicians love this, right? Emily, you agree?
Like a video game, right? Like
absolutely. For our younger population, that's really gamified, right? They're like, oh, I didn't hit that today, I hit this today, all of those things.
So case study. This is a 22-year-old female with pure motor hemiplegia with type 1 diabetes presents to the hospital, which she complained of hypoglycemia episodes and seizures. She was complaining that her blood sugar drops whenever she takes a small amount of insulin and can never really get a grip on how much insulin she should be taking. This patient's A1C was 12.5. A patient was admitted in the hospital and she had a blood glucose checked before meals and also at bedtime. And during her stay, the patient was noted to have occasional hypoglycemia episodes, prompting the hospitalist to recheck blood sugar levels almost every hour. This patient was diagnosed with uncontrolled type 1 diabetes. Now, is this patient, a good candidate for personal CGM device? So yes, this patient is an excellent candidate for CGM device. The reason is because of the frequent hypoglycemia episodes and not controlled A1C levels as well. Now, how can patients with uncontrolled type 1 diabetes care for themselves? These patients should eat healthy, try to eat low sugar and carbs, and so that lessens the swing in the blood glucose levels, exercise regularly, maintain a healthy weight, test blood sugar levels frequently, and track problems with blood glucose, for example, in a journal, so you can show it to your primary care doctor or endocrinologist, and also consider initiating a CGM device or insulin pump.
I just want a couple kind of closing remarks here. So when you're thinking about CGM and using it in your practice, really developing it in your clinical flow is going to be the easiest way to make sure that it happens well for your patients. So again, when in doubt, have a finger stick glucose as a backup so your patients would still have that possibility. The longer and more consistently it's worn, the more effective that it is. And that's why it's important too, when you're looking at that AGP, to see the amount of time that it was worn in those days. And that gives you a basis of how much to think about it. But the more that it's worn, the better information that you get. Looking for trends, not micromanaging excursions. And so this goes back to one of the questions we asked at the beginning about, are you going to make adjustments every single meal? For someone with type 1, you might be doing that with their insulin. But for those with type 2, that's probably not something that you're going to do at every meal. You're not going to change your dose of your basal insulin, for instance, based off of what your day was. You're going to look for trends overall as a physician when they come in and have that conversation about how you can change their management. Discuss the potential interfering substances and any other factors that may affect accuracy. And then data interpretation should be coupled with patient education to adjust medications and change lifestyle behavior. So again, that kind of shared decision making and that conversation back and forth with your patients.
Now, patients using CGM devices should be aware about the interactions that affect the CGM readings. The medications like acetaminophen or high-dose vitamin C may falsely elevate CGM blood glucose levels in some CGM devices, but not all of them. These effects may be dose-dependent and are caused by basically oxidation of the CGM electrodes by the medication itself. So the best practice before initiating the use of CGM device is to check the over-the-counter medication labels before taking them. Avoid acetaminophen when using automated insulin delivery system device. Check glucose with glucometer when taking acetaminophen, and test blood glucose more often when taking acetaminophen. Thank you for your attention during the presentation. I hope this has provided you with valuable insight into the world of CGM devices and their benefits for patients with diabetes.